Welcome to Duke Spine Institute's live stream of spine surgery. We're doing a patient who's traveled here. Let's drop the table half an inch. He's traveled here from where? Florida. North Florida, almost in Georgia. And he's here because he has horrible back pain and it goes into his legs. We're going to be fixing 4 discs this afternoon with him. The first one I'm going to access is 2-3. Hey, so I'm going to just talk to my team. You see how the foramen at 2-3 looks like it's got a double bone in it? But I'm looking at the transverse process, it looks good, but I think we're off on WAG just a little bit. I wonder if we can make that a little bit better. Sorry, not the transverse process, the pedicle. The pedicle at 2 looks pretty good. The pedicle 3 is off a little. I think that's better, right? Yeah. Is that 5 down there? 5, 4, 3, 2? You think that's 5? Yeah. So that's 5, 1 below, 5, 4, 3, 2. All right, let me go for that. It looks good. Let's give it a try. Shot. Shot. That's interesting. Shot. I feel like I might be hitting his TP. AP. That's got to be his transverse process. All right, so I'm going to talk to my team as we get the needles in position. That's the first step. Lay still, you're doing great. Yep, that's the TP. No wonder why. Back to a lateral. Because of his curvature, you guys can see the scoliosis, right, Henry?
Yes, we can.
So scoliosis just makes it a little bit more challenging for me to get to the disc that I need to fix. But it doesn't make it impossible. It just makes it a little more challenging. Shot. Shot. I think I'm going to start a little bit more medial. Shot. Shot. It's a little better. Shot. Still feel like I'm hitting his TP. Let's get an AP. Let's see where we are. Quick AP. Thanks, Luis. Any luck? Yep, there it is, the TP. Any luck with Karen?
No, I texted her a call.
Shot. Shot.
Should I call Ron?
Ron's not here.
Oh.
Shot. 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 Let's go with AP. His spine is crooked. He's turned off to the right side, so it's away from where I'm working. Just a quick one. That's the problem. I may have to start a little higher. Let's go some num-num. We're going to just give him a little more medicine. I'm going to reposition and start a little bit higher. Shot. Because of the scoliosis is making it more challenging for me to... Huh?
Looks like a better picture.
Shot. Yeah, I think I'm still hitting his facets. Shot. Lay still. That's better. Shot. 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 A lot of arthritis. Shot. Really close. Let's get an AP. Let's have the other needle.
Don't move.
Lay still, needle.
Lay still.
All right, let's go lateral.
It's got some lifting there, huh?
Yeah, it's got, no, it's just transverse process because of the scoliosis. It's very interesting, actually. It's pretty much keeping me from getting in. Shot. I have to go a little bit higher. Try to come down on it. Shot. Shot. Give me an AP. All right, so now I'm hitting his facet, which is better than before. Shot. Let's try doing an orbital adjustment. 1 degree. Shot. Worse. That's better. That is better. Shot. 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 AP. Let's just go quick APs, just whip it. So again, we're hitting, it looks like the TP. I may have to do an extra incision because of his transverse process. Shot. I don't know that I can get all of these with 1 incision. Shot. Shot. You need to get him more comfortable because he's got all this scoliosis. It's making it very complicated, and I'm having to maneuver things around. Lay still. Shot. Huh? Yeah. Shot. The problem is he's so twisted and arthritic that AP, it's made it almost impossible to keep him awake. That's better. Shot. Shot. Give me an AP. Looks good. Quick AP. All right, that's fine. Let's do another one. So that's 2, 3. We're going to go 3, 4 next. Shot. We're in 2, 3. I think we're okay. Shot. 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 His spine is just twisted so far away from me. Shot. Shot. AP. looks pretty good. Shot. Lower. Shot. Shot. Wait a sec, let me just think. Can we clean up 5-1 at all? May not be able to. Shot. That's bad, huh? Give me an AP. Alright. It's quite medial. I need to go a little more lateral. Shot. 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 Possible. Shot. AP. Mm-hmm. It's all the arthritis on the facet joint blocking me. I thought maybe, just maybe, we're dealing with a hitting the iliac, but it's not. It's hitting the facet. Shot. 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 It's too high. He does have a high iliac because of his scoliosis. Shot. 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 Crazy, huh? Luis cannot get in. I'm hitting against the iliac bone. Give me an AP. You're using a pulse mode, right?
Yes, sir.
Shot. There's the iliac. And then I could start a little bit higher, I suppose. Go ahead and go lateral. So the problem is he has a high iliac crest. Shot. Shot. Not able to get past all this arthritis over here. Shot. 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 That's fascinating. Shot. that might have gotten there. Nope, still too high.
That's Karen.
It's a little late now, shot. It's too high. There's no way. Shot.
Is that Karen?
Totally, thank you. We don't need her right now. Yeah, I cannot find a way in to 5-1. Shot. It's too steep. I'm hitting the iliac bone. Shot. There's just no way through that arthritis. Give me an AP. See that? I'm being trapped between the transverse process and the iliac. I'm not sure what else I can do. Keep hitting the iliac there. If I go any more north, I can get by it, but I'm going too high. Oh, I just cannot get there. Oh, there we go. Shot. Problem is he's deep, right? Deep?
Yeah, but I'm getting them, I'm waking them up.
Yeah. So I'm still too high. I'm too high in the foramen, I think. AP?
I'm gonna ask him.
Yeah, I'm not gonna keep it here. I think we need a more wake.
Okay.
But this thing is pushing my needle north. Yeah, I'm pushing me out to the side. You see that? I cannot get in there because of the arthritis of the facet joint. That's the steepest I think I've ever seen.
He's got a very hard job, so.
Huh?
Hard job, so.
He had a hard job.
Hard job.
His life has had a hard job.
His whole life,
Yeah. Shot. We're gonna go for 4-5. Let's clean up 4-5 a little more. I think, look at that, 4-5. I mean, are we off on orbit by that much? That's better. Shot. Shot. Nice guy. Give me an AP. So on a scale of 1 to 10, he's a 10 for getting to where we need to go. That looks good. Because of his twisting of his spine and the arthritis of the facet joints and the collapse of the disc and the high iliac wing.
How you doing, my friend? You okay? You all right?
Shot. We need him awake.
We're gonna ask you a couple questions, all right? Can you open your eyes for me? Thank you. We're gonna ask you some questions now, all right?
Are you comfy?
Are you comfortable? He said yes, he is comfortable.
Shot. Huh. All right. Amazing. Hmm?
I was trying to time the aesthetic to get up to this point.
No, it's fine. We didn't expect to have so much difficulty getting in. I mean, sure, he's got scoliosis, but how many people with scoliosis have we treated? That disc is really, really tough to get into. How long has he had back pain for?
10 years.
Shot? Uh-huh. 10 years. We're going to need to do the old Duke spine maneuver. Put it in when he's asleep. All right. I just can't get in. It's too tight. I need him awake, though. So our patient comes to us with back and leg symptoms. He has several problems, but really the issue is he's got some discs that are damaged, and he's having pain from these discs. We're going to test them.
How you doing, my friend? You okay? Yeah, he's all right. He's nodding, he's all right.
You having any pain?
You're having any pain right now? Yes, he's hard of hearing, so I'm going to yell a little bit. We have the hearing aids.
Where is it? How long has he had back pain for?
How long have you had back pain for?
10 years?
It's 10 years.
All right. I just want to make sure he's awake enough to help us. All right. How bad is that on a scale of 1 to 10?
Give us a number. 8. You just said 8.
Is that where you get your back pain? Is that where you get your back pain typically?
Is that the same spot? Yes or no?
Is that where you get your back pain? All right.
What'd you say? Yes, you said
All right.
yes.
Is it better?
Is the pain better?
Let me see the guide wire.
A little bit better.
What?
Pain's a little bit better.
What did he say?
Pain is a little bit better now.
Why?
Huh?
Why?
Are we gonna use the single, or are you gonna have one over here?
Oh, I'm just trying to get it in a little bit. See if I can get the needle in. Shot? I'm just trying to thread the guide wire down a little bit so I can get this needle going because... All right, pain's better?
Yes, he said that.
All right, so we know he had a 8 out of 10. And that was his typical pain he gets every day. Shot. How bad is that? How bad is that on a scale of 1 to 10?
Give us a number.
How bad?
9.
Is that where you get back pain?
Is that where you get your pain? Yes, he said. 9 and
Concordant. So 2-3 was a 9 over 10 concordant. 3-4 is an 8 over 10 concordant. And I can't do the 4-5. All right, we're going to put you to sleep. When you wake up, we'll be done. Shot. Try to cone down a little so we don't have so much white in the back there. You're radiating my hands too, so right there is good. Shot. All right. Shot. Can you see the guide wire?
Yes, we can.
Shot. Oh yeah, it looks good. It's all the way out to the front. All right, good. So we're going to have to make an extra incision than normal because his spine is so twisted that I couldn't get into the discs without starting at different places. Significantly different places. Shot. Shot. Perfect. Let's get an AP. Just a quick AP. Tell me when. Shot. Good. Look at that discogram. You can see the nerves, guys and gals. Show us the nerves there on that view once you get a chance there, Jordan. It's pretty cool to see the nerves. You guys see the nerve roots? That's the L2 and L3 nerve roots. All right. Henry, you see that?
Yes, we do.
Pretty amazing, huh? Go.
Is it okay for you?
Oh, he's perfect. Yeah. Shot. I don't know why this place got warmer suddenly. You feel that? Did you feel it too? How it got warmer? He gets stronger hands than me. All right, let's get the fluoro out. We're going to start with L3-4. Still trying. Trying to get that needle in, you know? We'll get it because we're right at the back of the disc. Scope on. If you have questions about the surgery or about anything related to the spine, feel free to ask us. We'll be happy to answer them. Sorry, Louise.
We do have a question.
Yep.
This comes from Teresa on Facebook.
Hi, Teresa.
They ask, can kyphosis of the cervical spine cause headaches, dizziness, neck pain, and leg weakness?
Hey, Teresa. It's unusual for kyphosis to cause any of those symptoms. I don't think so. We see kyphosis a lot, and usually it's due to muscle spasms in the neck. Most commonly, muscle spasms are due to disc herniations or disc bulges. So if you have a bulging disc in your neck causing neck pain, that would cause the muscles to spasm. That would then cause your spine to be kyphotic. But no, kyphosis wouldn't cause those other symptoms. We don't even treat kyphosis. We treat the underlying condition.
We have another question.
Sure.
This comes from Jenny on YouTube. And they asked, I am fused from T10 to my pelvis. I am 2 years post-op. What are the chances I will need another surgery?
So sorry to hear that, Jimmy. I don't know what the chances are, my friend. Why did they fuse so much? Do you know why? Was it because of pain? Or did you have a fracture or a tumor or a deformity? It's big surgery. I think there's a chance you're going to have what's called junctional failure. Junctional failure is when you say you fuse to T10 and then T910 fails. The next disc fails. And then you get either a fracture or instability there, and you got to fuse up even higher. Unfortunately, once you do the fusion, it's impossible to change it and go back.
They Jenny commented, scoliosis, very bad adult scoliosis.
Yeah, so I'm not sure why they fuse still, because this patient has scoliosis. We're not fusing him. We're doing the laser surgery instead. This surgery that we're doing now fixes the pain from scoliosis without actually doing fusion. It's a better option. So I would say that your pain you're going to get, Jimmy, when you get it, if you get it, it's going to be above your fusion at T910, or it's going to be below your fusion at the sacroiliac joints, SI joints. If you're having pain down by your butt cheeks, then it's your SI joints that are hurting you. We can fix it for you at Duke Spine without doing fusion.
Jenny replied back, wow, very interesting. Thank you.
You're welcome. I'd say the chances of you getting problems in your SI joints is very high. Probably at least 50-50 in your lifetime. I don't know how old you are, but assuming you're around 50 to 60, I would say you probably have a lifetime risk of 50% of getting painful sacroiliitis. Luis, it looks like the lenses are shifting.
You want anything?
No, I can do it, but I don't know. We may have to look at it.
Jenny replied back saying she's
See it?
51.
Yeah. Yeah, so you're 51, so you have a lifetime risk of about 50% of developing very painful sacroiliitis, which we can fix at Duke Spine using a plasma. It's called the Duke plasma rhizotomy. It's a 15-minute procedure, and it takes that pain away permanently through a few little, and you're under anesthesia for it, so no recall, no bad memories of anything. We keep you comfortable, pain-free. And if your pain is above your bra strap, assume you're female, but if it is, then it's your T910 that's failing. And that happens quite often, unfortunately. It's called junctional failure. Like a junctional box, a junction box. Junctional, adjacent segment disease. Another name. From what? Shit. You have cerebral failure. Neocortical failure. What's wrong? Everything okay?
No, just
Good?
yeah.
All right. A few more minutes here. And just about done. You guys see that at the top there? 12 o'clock?
Yes, we do.
That little bit of fat up there in the red, that is the outside the disc. So we are literally at the back of the disc. We're just about done here. A few more minutes and we'll be done. Some good questions so far. We're happy to take more. Have we shown our audience why do these discs cause so much pain?
Not yet.
Let's do that.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, now after watching this video, he's moving a little bit. You all understand that pain in the discs or pain in the back comes from discs. And specifically, not the whole disc, it's a small tear in the back of the disc. And that tear is called the annular tear. And it's inflammation within that tear that causes the pain that people get with a disc problem. Whether it's a herniated disc, degenerated disc, or bulging disc. Well, we can fix that area with a laser. And that's what we're actually doing right now. Fixing it with a laser. The nice thing about the laser, it's precise, safe, effective, very, very efficient. Meaning it gets rid of the stuff quickly, the bad stuff. Much faster than other surgical instruments. Done here. Going to move on to the next one. All right, so far we've had some good questions. We're going to move on to the next disc. You can probably see the nerve root. That's the nerve root on the left there. Done. So the pain that he had there should be gone. When he wakes up, he'll notice that. And honestly, this is our most successful treatment for patients with back pain and neck pain, is to fix their disc. The tear in their disc with the laser, and it takes the pain away 100% of the time in the disc. It's so reliable. It's the most reliable treatment in the world. Literally, I have not seen a single failure. Now, some people might come back, 6 months later and say, oh, I have pain in my disc again. But then they've always done something to re-herniate that they're not supposed to do. And they know it. Most of the time they'll tell me, oh, I was bending and picking something up. I knew I shouldn't have, and I felt a pop. But besides a reherniation, this procedure works. And it works really well, very consistent to get rid of disc pain. I've never had a failure. Come on in. We're going to move on to the next disc, which will be the L2-3. Again, another degenerated, herniated disc with an annular tear. Any questions?
Yes, we have a question from Canes25 on YouTube.
Sure.
They ask, good afternoon. Is that young man walking yet? No doubt he will soon.
Oh, yes, the young man is walking. He's already gone. He left a long time ago, a few hours ago. And he's not normal. Unfortunately, shot with spinal cord injuries, people don't get normal right away, completely. But he's definitely on his way. He's got very good strength. Shot. His strength is almost back to 100% in his legs. His problem is balance. His balance is not great. It's going to take time for that to come back. The reason for that is, you know, what we did was we did surgery to decompress the front of the spinal cord. Well, the front of your spinal cord is where your motor tracks run, and the front and sides of the spinal cord are where the motor tracks run that control strength. So his strength is definitely better. The problem is the back of the spinal cord is where your dorsal column medial lemniscus pathway is, and that controls balance. Shot? And his balance is still bad because that pathway has not recovered fully from the pressure that was on it, and more importantly, the swelling in that pathway. So I have confidence he's going to do fantastic. It's going to take time.
All right, my friend, hold on. 1 second.
Yep, no problem. We're going to wait a second, put the patient a little deeper. In the meantime,
All right, my friend.
you're doing great. Lay still.
Sure.
Ah. I must be hitting the end plate or something. This was the more painful disc. This was the 9 out of 10. Can't do it right on the disc. It's not the fascia, it's the disc. We've already put the local in the disc material. We put it in the discogram. Yeah, take your time. There's no rush. Uh-huh. Let me go? Still a little wiggly, but not as bad. Want me to wait? All right, questions? So you can see the first incision, 7 millimeters, tiny. Now we're at the second incision, and again, I could not do both discs with one incision because of the shape of the spine being curved. This patient has pretty severe scoliosis, but that's not the cause of his problems. His problems are coming from the bad discs.
Okay.
We have a couple questions.
Yeah, I'll be happy to take the question.
This first one comes from B3 on YouTube,
B3.
and they asked, how do reherniations occur if the nucleus has dried out and will not regenerate? Does that only refer to pains coming from an annular tear?
Ooh. How does the nucleus reherniate if it's dried out and
Will not regenerate.
will not regenerate? I see what you're saying. No, what herniates is the nucleus. If it's dried out, it's very unlikely to reherniate. It's probably not going to be a dried out nucleus that's reherniating. It's going to be a soft nucleus. The people that reherniate are generally younger people that have soft herniations, soft disc, and they do too much too soon. They don't listen. And so they end up reherniating a soft herniation through the annular tear before it heals. Looks good. Old dried up discs don't reherniate. That's perfect. It's juicy fat discs that reherniate. It's quite all right. I'll let you off the hook this time, Dr. Brenda. You know, we go way back, and it's the least a friend could do. You've let me off the hook before, right? Scope on.
Sitting, show on the sitting, please. On the
Scope, scope.
Thank you. And then lights off, please. Thank you.
All right, we're in that 2-3 disc now. Oh, piece of herniation right there. Great questions and participation from the audience, by the way.
We have another question.
Sure, I'll take all the questions you got for me.
This comes from Bali on Facebook. And they ask, hello, Doc. Are you the only one who carries out all the surgeries, or does anyone else in your institute also do them?
Great question. Great question. We have several doctors here, but I'm the one who broadcasts my surgeries, and I'm the one who does question and answers. The other doctors don't broadcast their surgeries. Why? Well, a lot of reasons. Most importantly, the surgeries are short. They do pain management procedures, epidurals, facets, and we do broadcast some of them, but they're very quick, very short, and really, by the time you guys get seated down and watching, we're already done. So the reason why we do the spine surgeries is because they take longer, and you can sit down and watch for an hour, get your questions answered. Also, I like teaching, so I do the teaching during my surgeries. Other doctors like to focus more on what they're doing. Maybe they don't like teaching as much. I don't. I'm used to teaching while I work, so I'm happy to do it. Just preference of the doctors, but I'm not the only surgeon. We have Dr. Patel, who is, in my opinion, the best interventional pain management doctor in the United States. Dr. Bharat Patel. He's worked here now for how long? Let me think. About 16, 17 years, right? No, 16 years. He is an amazing interventional pain management doctor. He does surgery. He does spinal cord stimulator, epidural, thoracic cervical lumbar epidural, sacroiliac joint. He's my assistant surgeon when I do surgery. And look at that scar tissue there. We have Dr. Frances Cheney, who's also interventional. She's Dr. Patel's latest fellow that he just finished training. She's very, very smart, very good, but she doesn't do the teaching and broadcasting, okay? Again, I'm the only one that does. And then we have Dr. Davis, who just joined us, orthopedic surgeon. And we have Dr. Berndes, who doesn't really do surgery, but he does surgery. I mean, he's an anesthesiologist. He's not performing surgery. He's the anesthesiologist for the surgery. So we have really 4 surgeons now, but I'm the only one who broadcasts the surgery and teaches. Boy, yeah, we definitely need to send this scope in. You can see there's bone spurs, herniation, a lot of inflammatory tissue over here. Bone spur there. Great questions so far.
We have another question. This comes from Teak on YouTube.
Hello, Teak.
And they ask, are you the only one doing the DLDR? I assume yes, but for the viewers to know.
Yes. Yeah, I'm the only one here that does the Duke laser disc repair. The Duke laser disc repair is a surgery done on the spine, done on the discs. And I'm the only one doing those right now, but Dr. Patel will be doing them soon. And Teak, we have a lot of people who need treatment, and they've been contacting our institute, and we are getting busier. Ask Luis. Right, Luis? Oh yeah, he says. So, yeah, because we're getting busier, we have to have more doctors. And Dr. Frances Cheney just started. She was our fellow for a year. She's been trained by us. She's very good. Everybody loves her. And then we have Dr. Davis, who everyone's going to love. He's awesome. He's an orthopedic surgeon. He's going to be doing the Duke plasma rhizotomies on the hips and knees. Grab her. Shoulders eventually, maybe, but primarily hips and knees. That's the procedure where we go in and kill the pain nerves to joints to get rid of pain. He's an experienced joint surgeon. He's used to doing total joints, like total knees, total hips, partial knees, partial hips. That's his specialty. And now he's converting because he's seen the surgery done, the Duke plasma rhizotomy, and he wants to join us. And I'm going to try the laser again. He wants to join us and do the Duke plasma rhizotomy. He's a good doctor. He's a good man. He cares about the patients. He wants to do the least invasive treatment for people to get better, something that works. So a lot of surgeons are out there trying to do 30 knees a day at the hospital. They're racking up the business. We're not interested in racking up the business. We're interested in fixing people in the least invasive way possible. So we're not about numbers, we're about quality, and he's about quality. He wants to fix people the right way, less invasive. So that's why he's joining us. He's stopping the rat race. He's stopping the big push for implants, and he's going to come do the minimally invasive treatments that we do here. Just about done. We got one more to go. Great questions. Scope off. 2 down, 1 more to go. Please do. Remember, we could not get into 5-1. It was impossible. And it's not because the disc. The disc is fine. The disc I could get in. It's got good height. It's because of the high iliac crest, the extremely enlarged facet joints that are enlarged and twisted to the right, to the side that I was trying to go in. It was a scoliosis, and that was pretty much it. Those 3 things prevented me from getting in there. 2 down. Let's move on to 4-5. Go ahead. Any questions you all have for me?
No current questions, but we do have a comment from Teak, once more on YouTube, saying, I have a new cervical MRI scheduled. I am trying to convince my doctor to allow me to get a new lumbar and thoracic order as well. Then I will resubmit to your team and get a consult with you.
All right, Teak, that sounds great. I look forward to it. Thank you for sharing, and thank you for caring. So this patient is our almost last patient. We have one more. And knife? Huh? I know, but I think we're sitting on the end plate. That's why. Knife? We do have the last patient, who's an interesting one. We're doing a cervical facet, a lumbar facet, and one level DLDR for the disc on the right side. So, sorry? Left side. Did I say?
It's going to be pro. Yeah, everything is going to be yeah. No worries.
Shot. So you can see we've got our guide wire planted at the back of the disc. Let's do some num-num. Shot. Is that it where we are? Here we go. All right. Shot. That's us.
Yes, sir.
I need to aim down. Shot. Pull the guide wire. Go ahead, pull it. Take this. We're under the root, we're fine. Shot. Yeah, you're right. Fascinating. He's kind of auto-fusing. What is it?
No, you said it.
There we go. Yeah, that's a really degenerated disc there. It's going to be fun. The back is so calcified that I had a hard time getting in. Straighten it out. Uh-huh. Okay, here we go. I got it. See? The angle is bad. You want to try to pull it back a little? You may need a wet 4x4. It's coming?
Yeah.
C. Perfect. Let me go a little more. Just a bit. All right, good. Tough disc to get into. Patient's disc is really scarred up. A lot of inflammation. You can see it on the x-ray, all that arthritis. That said, I still feel confident we're going to get rid of his back pain, despite all the stuff you're seeing. Scoliosis, degenerative disc disease, facet arthropathy, stenosis. We do these procedures all the time, and they work. We don't make the spine pretty, right? As Dr. Berndes said, we're not doing cosmetic spine surgery. However, we make the spine feel good. That's what we're trying to do. This disc will be 5 minutes, 6 minutes. Thank you. All right. I would recommend you ask whatever questions you have. Is our last patient here? Yes, yes. All right. Therapeutic metal staking. You all right? This is the time of back pain. You're not the only one with back pain. You'd be amazed how many people have back pain. All right, why am I feeling a cold foot? Oh, there's no suction here.
Hey, what happened to the sucker on the other side?
All of these things are on my end.
Can you check on the sucker on the other side, please? Yeah. You have to connect it to the back. That's right.
It's not connected.
It's over here. It's probably with the, yeah, with the machine or something. I got it.
All right, we're just about done with the surgery. Probably another few minutes to go. I've got to get these really dried up pieces of herniation out of there. There's one. Anybody see any good movies lately?
Sound of Freedom.
Mission Impossible, Sound of Freedom? So did you watch the Mission Impossible? Was it good?
That's
You
out
heard
already?
it? Huh?
That's out already? I thought it was coming out this tomorrow, actually.
Is it in theaters or where is it?
I'm looking this up. Hold on.
Oh man. 2 minutes. Burn this. 2 minutes and counting. What movie? Anybody know?
Oh wow! No, it came out yesterday. Mission Impossible
Mission Impossible.
came out on a Wednesday. Box opening night, 18 million in the box office.
2 minutes and counting.
Oh, we just got a question.
Moonraker. James Bond. Yes, we'll take the question.
This question comes from Bali, once more on Facebook, and they asked, how many surgeries do you do in a day on average?
How many surgeries do I do in a day on average? Great question. Well, I operate 2 days a week. So I would say, gosh, we've done everything from 0 to 5 or 6. Today is about as tough of a day as it gets. 5 surgeries. On average, probably 3 a day on my operative days over the last 6 months. But it's definitely going up. We are getting busier and busier and busier. And I say that in a good way because I love fixing people's backs and necks. I love it. It's my favorite thing to do. As I said before, my wife, laser? My wife tells me I should retire, but she also knows I always say no because I really like this. I really like what I do. I'm not going to retire. I'll probably die in the operating room. I'm sure they'll code me one day. Dr. Berndes, 20 years from now, 15, you may be running a code on me. Well, it's true, you know, none of us live forever, and
Well, the staff will have to practice coding me first.
you cannot be coded before me, all right? Um, I honestly love what I do, and I see it as my mission from God. If you've ever watched The Blues Brothers, okay, one of the best movies ever made. If you've not watched The Blues Brothers, please do so. Okay? It's one of the most important movies of our American culture. Blues Brothers.
Agreed.
And if you listen to them, they are on a mission from God. And my God, there's some incredible people in that movie, right? Dan Aykroyd, John Belushi, Aretha Franklin.
Yeah, she was in it.
I mean, some of the. Oh wait, what is it? Little Richie, or who is the singer?
Oh no, Little Richie. He was in it.
War. Who sings that war song?
I'm looking at.
You know what I'm talking about.
Yes, I do know what you're talking about. James Brown.
James Brown.
James Brown.
Oh man, they have so many important people in our culture in that movie. So please, Blues Brothers, if you haven't seen it, and you'll know when I say things. I say things during surgery that go back to many years ago, our pop culture. If you like American pop culture. I grew up in American pop culture from the 80s, 70s, 80s, 90s, okay? So you hear me say things sometimes. There's a meaning behind it. And if you like movies and American pop culture, you'll understand a lot of the things I say. But anyway, I feel motivated, spiritually motivated to do what I do. And I know that it's a good thing and it's a right thing. It's righteous. It's righteous, man. And that's why we do it. Otherwise, I could have retired. I'll be honest. I'm sure my wife's really happy I'm not retired. Because if I was, I'd be around the house all day bothering her. And she'd get sick of me. We have a joke in the family, and that is that she got me 5 dogs so that when I come home, I don't bother her, I bother the dogs. Anyway, I think she's perfectly happy to have me working. So, I'll be working for a long time. All right, we are done. I'm just cleaning up the last bit. Coming out here, let me just take a peek. Incredible. That's the facet joint right there. You guys see that?
Yes, we
Facet
do.
joint. I'm literally shaving the capsule off the facet. Okay? Yeah, this scope definitely needs some repairs. You know what I mean? All right, great job, everyone. I think that went really well. The nerve root will be right up there. You guys see the nerve root right there?
Yes, we do.
See the white thing? It's got some blood vessel on it, a little vein right there. That is the nerve root, and look how scarred up it is. Let me get the laser back for a second. There's just the tiniest little tag below it. I want to just zap it, just to make sure. Right here. All right, that should do it. All done.
Lights on, please. Thank you.
Thanks, everyone. Great job. Oh, you know, I'm pretty healthy otherwise, and I love being here doing this stuff. And the more people we can help, the better. So people think I just operate, but I don't. I spend about 70% of my time running the business and coming up with ideas with other people to, you know, expand and reach more people and help more people. Creative ideas. So I'm constantly doing things. If it isn't in the operating room, it's in the clinic or in the admin office. But I want to see a day when there's nobody with back or neck pain anymore, because they've all been fixed permanently with this procedure, the Duke laser disc repair or the Duke plasma rhizotomy. And I really think it's achievable. I think if everybody knew about this procedure, that they would choose to have this done rather than live in pain. And of course, they wouldn't want a fusion or artificial disc because it's totally unnecessary. What do you all think? You agree? Can we get a hoorah?
Hoorah.
All right, I love it. Any more questions?
No current questions.
Folks, type up your questions if you will, and why don't we just go ahead. Actually, let's end the stream, and we'll be back for one more surgery. If you have questions, type them up.
Copy that.
All right, thank you.